So every time a patient with an eyelid lump or bump walks in, most of us would start looking for a signs of chalazion and more so start hoping for no signs of an eyelid malignancy. But beyond these two possibilities lies the spectrum of benign tarsal related cysts. These include a range of different types of benign epithelial cysts which share clinical similarities, are anatomically related to the tarsus, but have minor histopathological differences. Our pathology colleagues rely on some striking clues like the gross and microscopic appearance of keratin, the lining epithelium amongst many others before they stamp their reports. But as clinicians, the only differentials that is relevant to our management are a chalazion and a malignancy. A malignancy will have a completely different picture with loss of eyelashes, meibomian gland dropout, distortion of eyelid margin amongst many others. The challenge lies in differentiating a benign tarsal related cyst from a chalazion. In all fairness, even the best of us can easily confuse these well circumscribed progressive smooth lesions fixed to the tarsus as chalazion and treat them with an incision and curettage only to end up with a recurrence. But definite clues like lack of inflammation, slow growing, soft to firm, fluctuant eyelid lesions within tarsal height with no response to antibiotics and a delayed recurrence are the holy grail to tell them apart from a chalazion. We present to you a retrospective consecutive interventional study of 53 histopathologically confirmed benign tarsal related cysts which assessed the entire spectrum, explored preferred surgical techniques based on cyst base and involved tarsal thickness, and gives definite ways to reduce recurrence. We found no sex predilection in our study. The patient profile included majority of them in the 4th to 7th decade with a mean age of 52.7 years. Where 85% of them were gradually progressive. 100% of the lesions were well circumscribed, smooth and non-tender with no signs of inflammation, of which 45% were soft and firm each. 82% of the lesions were mobile, while 18% showed tarsal fixity, either with a yellowish-white nodular bulge or bluish discoloration on eyelid eversion. From a detailed analysis of our cohort, we suggest the following surgical algorithm. We begin by assessing the lesion's prominence on either skin or the conjunctiva to decide on a skin or conjunctival approach respectively. Then we assess the cyst base with involved tarsal thickness. If the lesion has a large base, the involved tarsal thickness will not matter. But in case of a small base with no tarsal fixity, smooth cyst excision works best. For a superficially adherent tarsal cyst, excision is augmented with partial thickness tarsectomy. And for a small cyst with full thickness tarsal involvement, cyst excision with full thickness wedge tarsectomy gives the best outcomes. While in case of a large base, a full thickness tarsectomy would leave a huge tarsal defect. Hence, marsupialization works best, which essentially means exteriorizing the cyst base. Augmenting marsupialization with either cryotherapy, cautery, fulguration or alcohol ablation or any combination of the above to the base to eliminate any residual cellular lining helps achieve close to zero recurrences. This is a summary of the preferred surgical techniques used to manage our cases. The histopathological distribution of our cases revealed majority of them as epidermoid cysts followed by inclusion cyst, retention cyst and intratarsal keratinous cyst. These are some outcomes of our patients with excellent aesthetic, functional results and minimal risk of recurrence. Ours is the first study to review these lesions with the longest follow-up period of about 75 months, which concludes how despite histopathological variations, a clinician can use an algorithmic approach of surgical techniques based on tarsal base and involved tarsal thickness to achieve optimal results. As the third most common tarsal lesions, these benign epithelial cysts warrant a high degree of suspicion. Despite the glaring similarities with the chalazion, a keen eye for the differentiators can help to tell them apart. Always rule out a malignancy first. A methodic, algorithmic surgical approach based on cyst base and involved tarsal thickness can provide gratifying results for the surgeon and the patients alike. Thank you.
Excellent study with a great sample size, and the follow-up is also good. So LPS, so it was how many cases you requires to reattach?
3 cases.
Out of 53?
Yes.
Okay.
we have to look for that when we are operating, and in case that is involved during the accession, then it has to be reattached.
Any more question? Thank you.
Thank you.